Diagnosis and treatment of cerebrospinal fluid leakage with a navigation system. Xiaozhang, Radiology Department, First Medical Center, the PL General Hospital. 1 patient general information. The patient was a 63-year-old male who experienced unexplained swelling and pain on the top of the head in April 2024. The numeric rating scale (NRS) score was 4-5. Following head movement, the cervical spine pain score increased to 7-8. From April to August 2024, multiple medications, physical therapies, and conservative treatments were ineffective. On August 20, 2024, the patient was admitted to the Department of Neurology at the PL General Hospital for a lumbar puncture. The cerebrospinal fluid pressure was 35 mmHg. In September 2024, the patient underwent cerebrospinal fluid angiography, an autologous blood transfusion repair surgery using electromagnetic navigation system. Preoperative preparation. Patient preparation, preoperative health assessment, laboratory tests, and imaging studies were completed. Informed consent was obtained. The patient's drug allergy history was confirmed. Anticoagulant medication and psychological counseling were administered as needed. The patient fasted for 4 hours prior to the procedure. Required equipment and drugs: 21 gauge G puncture needle, ioxol contrast agent, 5 ml and 10 ml syringes, 0.2% lidocaine injection. Guidance equipment: Philips large aperture CT scanner, Paripath electromagnetic navigation system. 3. Operation steps. The patient was placed in a prone position. A positioning pad was used to elevate the hips as much as possible, and ECG monitoring and venous access were established. The electromagnetic navigation system was positioned beside the scanning bed, and a positioning box was attached to the surgical site. A preoperative CT scan was performed with a 2 mm slice thickness. The images were imported into the navigation system for 3D reconstruction and spatial registration. The puncture path for sacral myelography was planned by the operator via the navigation interface. Mounting the puncture needle. The following was the details of mounting a sensor on the puncture needle. After taking out the needle clip from the packaging bag, clipped it to the scale at the end of the puncture needle for distance calibration. With the help of an assistant, inserted, rotated and snapped the sensor into the hole of the needle clip. Disinfected locally, sheeted a bed with a sterile sheet, anesthetized locally with 0.2% lidocaine. Performed puncture with the reference of the navigation interface. CT was used to monitor and to conform the needle tip entering the subarachnoid space of the spinal cord, then the needle core was removed. When the syringe was withdrawn, and a colorless clear liquid was found, it proved that the puncture was in place. Used a syringe to slowly inject 5 ml of ioxol. Monitored continually to the patient's reaction and changes in vital signs. After confirming that the contrast agent had diffused well through intermittent CT scans, withdrew the puncture needle. Took the side-lying position and measured the pressure. The patient quickly adopted the chest-knee position for 30 seconds. Then helped the patient roll 3 times to evenly distribute the contrast agent in the subarachnoid space. Thin slice CT scanning and 3-dimensional reconstruction were used to observe the extravasation of contrast agent, and the leakage point was confirmed to be the 5th cervical segment. The patient was placed in a prone position, keeping the head and neck in a fixed position. The puncture path was planned by the operator on the interactive interface. With the reference of the navigation interface, bilateral subdural puncture was performed at the corresponding leakage point. CT scan to confirm needle tip position. After the puncture was in place, the diluted contrast agent was injected to identify the injection location. After the autologous blood injection site was confirmed, 20 ml of the patient's autologous blood was collected. Slowly injected about 10 ml of autologous blood through the bilateral puncture needles. Monitored continually to the patient's reaction and changes in vital signs. Performed CT scan to confirm good diffusion of autologous blood at the injection site. Removed the puncture needle and applied a patch to the local skin. Performed a full spine CT scan again to observe the overall situation inside the spinal canal. Under the supervision of the doctor, the patient returned to the ward. Tried to keep the body in a prone position for about 3 hours. The patient's headache improved the next day. After 3 days, the headache situation improved significantly and the incidence rate decreased significantly. 4. Conclusion. In this case, an electromagnetic navigation system was utilized to simultaneously perform cerebrospinal fluid angiography and autologous blood patch repair. This approach demonstrated multiple advantages: enhanced precision and efficiency, high puncture accuracy and reduced procedural time, reduced radiation exposure, significantly decreased CT scan frequency and cumulative radiation dose, standardized technique, lower dependence on operator experience, thereby facilitating the adoption of minimally invasive techniques in clinical practice. Thanks for watching.